So thanks very much, Paul. Thanks, Sophie, for dimming the lights. Look, thank you very much for inviting me to talk. It was actually quite enjoyable putting this talk together. Going through all the different roles the interventional radiology plays, and I was interested to hear a few questions about, ethnicity and cultural. I think that this slide shows that everyone is actually different how they tolerate pain. So that actually does come into play. That I think the pain assessment we rely on as interventional radiologists, that we rely on our pain referrals, that a lot of that assessment is done before they come to us. But obviously pain in cancer patients is very important, and it's very relevant, and it's very well accepted. 90% of cancer patients will experience pain, and more than 50% in advanced stage will report moderate to severe pain. And they experience both nociceptive and neuropathic pain, and bone and visceral pain are certainly the most common sites. So what are the various techniques that we have in our kit bag, various tools as an interventional radiologist? We have neurolysis, ablative techniques, vertebral and bone augmentation, and we have intraarterial treatments, namely embolization and other treatments such as SIR therapy, which is selective internal radiation therapy or treatment. So we'll go through those various options. So neurolysis, what is our aim? Our aim is often for visceral pain to target relevant sympathetic plexus. We want to damage the pain fibres and but not affect motor or sensory function. We have chemical options, which, as Charles had mentioned, phenol or alcohol are our options that we can choose. And there's no, most studies, long-term studies, have shown there's no significant difference in pain response or complications associated with either agent. So people tend to start with one and get used to it and use it. But certainly I use alcohol mainly, and we'll show an example of that. Also, people have used thermal ablation for neurolysis as well, with radiofrequency ablation and cryoablation. The plexus targets include celiac plexus, which I'll talk a lot about in detail, but there are a number of options: the superior hypogastric, ganglion impasse, stellate ganglion, thoracic lumbar sympathetic plexus, peripheral nerves, intercostals, brachial plexus, so a number of options depending on the patient. And overall there's a very, generally a good response rate of some degree and improvement in quality of life. So with the celiac plexus block, it's patients with upper abdominal visceral pain due to splanchnic or intestinal cancers, and it's typically the pancreatic cancer patients would get mostly referred. And you can see that why anatomically we'll go through why they're a particular risk of involvement. And again, most studies have shown that they do get a significant improvement in pain, even if it is only short-lived. Some get a more long-standing pain relief, but it is a bit about picking the patient, which we'll talk more about. So, and the stellate ganglion for pancreas tumours in the superior sulcus of the lung and also in the neck, and superior hypogastric and ganglion impasse for visceral pelvic malignancies and perineal pain. So I'm just going to talk about the celiac plexus block. I think the technique, this used to be done a lot under fluoroscopic control, and I think more and more it's moving towards interventional radiologists and using CT guidance. And I think it's pretty obvious why. Well, that's not projecting well up there, is it? Sorry about that. Do you know that might be something? It's not projecting differently. Anyway, well, I'll just keep talking. So this is basically a zoomed up image of a patient with a pancreatic cancer, and this is actually a low density pancreatic mass. I'm just showing this because this is the aorta, this is the right and left crus of the diaphragm, adrenal gland, IVC, portal vein, gastroduodenal artery, duodenum. Okay, and then we get into small bowel. So, thank you, that looks better. So, so basically it's really to show you this is in tiger country, because the celiac plexus is located, as we'll talk about, between the celiac artery and the root of the SMA. So you really are in, but you can see how pancreatic cancer with some extension posteriorly is very susceptible to invading the actual celiac plexus. So the anatomy is challenging. Okay, so you need the best image guidance in doing this technique, and CT is ideal. It's the largest visceral plexus between T12 and L1, as I said, around the celiac artery and SMA. It's composed of various ganglia and involves the splanchnic nerve from the thoracic sympathetic trunk and abdominal branches from the vagus. It's variable in length. One important point which I wanted to mention, because this comes up in the complications, is that the artery of Adamkiewicz, spinal artery of Adamkiewicz, which you may remember from anatomy days, very important artery. It basically supplies the lower thoracic and lumbar part of the cord, and so if that is inadvertently damaged, it causes paraplegia. So it's obviously, when I start with patients and I'm talking to them about it, it's the first thing I have to say, look, it's a very, very, very rare complication, because as soon as some people hear that, they just shut down and don't want to think about having the procedure. It is extremely rare, fortunately, and we'll talk about the actual rate of that. But it's often in the vicinity, and you don't know really where it is unless you did a spinal angiogram, and it's not practical to do a spinal angiogram on these sort of patients to find out exactly where it is. Okay, so you need enough neurolytic agent to block the sympathetic afferent nerve pathway from the viscera. So we actually put in quite large volumes. All right, so this is a typical patient who, this was the same patient, and interestingly, you may have noticed, people might be saying, what's this big thing here? This is actually a big renal cyst. Okay, so all patients will have things which get in the way. This patient's quite good because they've actually all this black stuff, and people who aren't used to looking at CTs, I love showing patients. I go, what do you think this black stuff is? And they go, I don't know, doc. What is it? And they get all excited, and I say, it's fat. And they go, oh my God, it's like half of me. I said, oh well, So it's actually quite a good for weight loss program. You show them their CT scan. But in cancer patients, they're often cahectic. So we actually like a bit of fat as a radiologist because it gives us a natural contrast. So I can see, it outlines the organs for me. So I can see where the celiac axis is. I get this fat plane around there. So I can see black around it. So that's the aorta. This is the celiac axis coming off here. So in cancer patients, this gets harder because everything is stuck together and there is a lack of fat planes. So this is showing our standard approach would be to do a 4-needle approach. We put one needle on either side around the celiac axis. We also put them in the retrocrural space to get the splanchnic nerve. So studies have shown that if you get all 4, if you can get needles in 4 places, if you inject and infuse, you'll have a higher success rate in reducing that patient's pain. Okay, so patient preparation is very important. So they need to cooperate with the breathing. They need to be afterlie prone. Okay, so you need to get their pain control as best under control before you start the procedure. You need to obviously get them in for a consultation before and explain the procedure at length, because you can talk about breathing and what they need to do. As we said, CT guided. We do a test injection at the start, so with contrast and local anaesthetic. That's really important, obviously, to see if they get some sort of response, but also to make sure that they don't start saying, oh, I'm getting all this sort of funny sensation down my legs. Then you think, oh my gosh, I might be close to the artery of Adamkiewicz, and maybe we've injected inadvertently into it. Obviously, we're very careful. We try not to do any intra-arterial or intravascular injection. So as I said, we use ethanol or phenol. This is the classic mix that most people use these days. You need dehydrated alcohol greater than 50%. So we get it at 100%, and then we actually dilute it with a little bit of Marcaine and contrast. Contrast means we can see where it's going. We can see where it's gone afterwards. Marcaine, obviously, for local anaesthetic effect. And 30 to 60 mils, so it's quite a large volume. But if you're separating that over 4 sites, it's not a lot in each site. But you will see afterwards. So if I just show you, these are some needle placements that we've done here. And these are 22 gauge needles, so you might think, oh my gosh, look, we're right next to the aorta. It is tiger country where we're going. But a 22 gauge needle, most people tolerate that anywhere. So even if that did go into the aorta, if you pulled that out, 99% out of 100, that would actually that hole would plug. So although it looks terrifying, it's actually not as dangerous as it looks. So this is the test injection where we've actually injected some contrast, and that just shows us where it's outlining, and we make sure it's not intravascular. Okay, so what are the complications? Well, anytime you stick a needle in someone bleeding, and a hematoma, and particularly in the prone position, high up at the T12, L1, the lung comes into play. So I do have to counsel them that there's a chance of getting a pneumothorax if you have to go through lung. Very manageable, very treatable, not a big deal. Intravenous injection of alcohol we worry about because alcohol destroys most things in its path. So if you inject it intraarterial, intravascular, it will occlude that vessel. Can cause hypotension, usually transient, orthostatic due to the sympathetic block and visceral vasodilatation. Chemical peritonitis is in the list of potential complications. Very rare from the posterior approach. Some people who can't lie prone, you can come anteriorly and you actually go through, basically you can put a 22 gauge needle through the liver, through the pancreas. You can put it through stomach, small bowel. You really don't like going through colon because that can lead to peritonitis in itself. So diarrhea, usually transient, but can be chronic. So that's another one of the ones where people go, oh. So that's due to persistent sympathetic block and increased parasympathetic drive. And the paraplegia, as I mentioned, 0.15%. Now, unfortunately, I've never seen it, and as I said, with the test injection, hopefully that's reduced to, that would hopefully alleviate that. But the test injection is only a small amount. You put 5 or 6 times the amount when you're actually doing the injection. So there's a chance that the test injection won't exclude that risk. That's just showing you a picture of the spinal artery of Adamkiewicz. I still have struggled with the spelling and I still have to look it up every time. But you can see this is it. It does this classic hairpin turn. Okay, so we're always looking out for that when I do preoperative embolizations, which we'll talk about in a tick. This is actually someone who was having a workup for a T12 vertebrectomy. That area of black, this is a digital subtraction angiogram, so all the bones have been subtracted. That's actually enhancement of a tumour inside the T12 vertebral body. So this patient, we actually decided this was a preoperative embolization for Paul Stalley, and we had a long talk about it and we woke the patient up, which we do anyway between the embolization and the operation, and she decided to not have the operation because of the high risk of paraplegia after it. So percutaneous ablation. What are our options? RFA is the most commonly used or widely used. Most literature have been around the longest. Microwave has come into play and replaced RFA in certain areas, and cryoablation also has replaced. Predominantly used in pain patients for bone metastases in both the appendicular skeleton and the spine. It's usually reserved for when radiotherapy is unsuccessful or contraindicated, but there are advantages to it over radiotherapy in the fact that you often can get a faster onset of relief. It's a one-off procedure, although it's done usually under general anaesthesia. But it can also be combined with bone augmentation, which can be advantageous compared to radiotherapy. The method of action is thought to be multifocal, destruction of pain nerves at the periosteum interface, inhibits osteoclasts, reduction of nerve-stimulating cytokine production, and tumour debulking. What is RFA? So it's basically high-frequency alternating current, which causes ionic agitation and leads to coagulative necrosis. So you really need to get temperatures up greater than 55 degrees. You want them higher than that. That's a minimum. So 60, 80 degrees is where we're trying to aim to get. Now, bear in mind that you've also got to be mindful of the structures that you're adjacent to, because that's the risk of this procedure is damaging adjacent structures. Microwaves is another form of thermal ablation using microwave energy. It's faster than RF, so you can actually get a faster, larger burn. So certainly in tumours such as liver and renal tumours, most people have moved on to microwave because it is faster and more effective, and you can treat larger lesions. Heat sink is mentioned up there. That's basically RFA. If you're close to major vessels, you try to get the heat. The vessel actually takes the heat away because it's a flowing vessel. So you often get an incomplete ablation close to a large vessel. Sorry, cryoablation. If I just go back to cryo. So you have to put these cryo probes are inserted, and then you have this argon gas high pressure argon gas, which is infused through the cryoprobes, creates this ice ball of temperatures down to minus 100 degrees. And then it's re-thawed with helium, and you have these cycles of freezing and re-thawing. So it's cost. The advantage is that you get this clear delineation of an ice ball, so you're very accurate. And less pain post-op than other ablative techniques. But it is very, it's time-consuming and it's very costly to set that sort of program up. This is just a brief thing which I'll run bypass, just showing an RF circuit. You have to have a dispersive electrode, so you have to have a grounding pad here, and this is one which actually has a cool tip system where actually this is mainly for solid organs, where you actually cool the tip of it so that you don't get charring around your needle tip and you get a larger ablation zone. Just an example of it being used, this is a microwave ablation in a scapular RCC metastasis, which was very painful. Bony mets, so this is the probe coming down here, this is the part of the scapula, and this is the sclerosis in it. Sclerotic mets can be hard to actually get into because they're very dense and hard. So lytic mets, mixed lytic sclerotic mets tend to be easier, but sclerotic mets can be done, but they require often a coaxial technique, which means you put one needle, a larger needle in first, or you create a hole with a bone drill to enable you to get your probe into that lesion. This is just this is an osteoid-osteoma, so it's not a cancer, but this is a nice example of getting into tricky spots. So this is a 20-year-old who had a painful rib osteoma, and just to show you where it is there, because it is hard to see. So you can see that there. So basically there's a loosened area in the neck of that rib, okay, with a sclerotic rim. Okay, fairly classical appearance of an osteoid-osteoma, and they can cause a lot of nighttime pain. So what we did is basically with a 13-gauge bone biopsy needle, we basically got into that lesion and created a tract. We then removed that, and then we put the RF probe down into it. And then we basically used the RF probe on several cycles for probably about 20 minutes on repeated cycles, and the patient literally woke up the next day and hasn't had any pain since. So it's very effective. Just a quick slide on cryo. It's a similar technique for what, as an interventional radiologist, it's basically sticking a probe using image guidance, and most of us would use CT guidance or ultrasound guidance depending on how superficial it was. There are cryoablation MRI compatible things now, so so that's very helpful because a lot of tumours, for example, renal tumours, you can't actually see. You can't see them very well on other imaging modalities. So obviously the infrastructure cost of setting up an MRI-compatible cryoablation is very large. Just wanted to show this image here. This shows you nicely what the ice ball looks like. So you get this well-demarcated low density, and you can actually see that linear, very black stripe. That's actually where the probe was, so you get this sort of mask of where the probe was. Contraindications to ablation. As I said, it's collateral damage you need to watch out for. So adjacent to hollow viscera, particularly the colon, we're very nervous about. You can inject various agents to push the colon away, such as dextrose. You can infuse dextrose and give you a few centimetres. RF is limited by size, so when the lesions are greater than 3 centimetres, we prefer other tools such as microwave or cryo, and obviously proximity to spinal cord is an issue. So the complications are rare. Again, probably the biggest thing is just to remember that we do leave tissue behind. Unlike surgery where you actually remove the tissue, we actually leave a bit of dead tissue behind. So that is a nidus for potential infection. So the patients can get infection more commonly after ablative techniques. Obviously it's done as a very sterile technique, so to ensure that there's no insertion of any bugs at the time of the procedure. Thermal damage around surrounding structures we mentioned, and very rarely it can weaken bone and lead to fracture. But in those sort of situations you might think of combining it with augmentation, which is basically injecting some cement into that lesion to give that stability back. All right, that leads us on to our third area, the vertebral and bone augmentation. Vertebroplasty we'll spend most of the time talking about. There's also kyphoplasty, which is a variation of vertebroplasty, and cementoplasty, which is injecting cement sort of not in the spine, so a very similar technique. So what is it? It's an injection of a very fast-setting cement called PMMA via a pedicular approach, so transpedicular approach, either one or two pedicles. And it's for the painful pathological or osteoporotic vertebral body fractures. Remember that cancer patients suffer both, obviously, infiltrated pathological fractures, but they also get an increased risk of osteoporotic fractures. And this treatment is effective for both. And ideally, more studies have shown, and particularly a recent study, the VAPOR trial, have shown that if you have severe pain related to a fracture of less than 6 weeks duration, you get a good effect if you get in there early and treat it. You get the patients out of hospital faster and you get a better pain relief. It's about picking the right patient though, as we'll talk about. There's a twofold effect on pain reduction. You get mechanical stabilisation of the fracture. It's the fracture of the microfracture which causes a lot of the pain. But also if it's infiltrating, you can get an exothermic reaction apparently, which from the heat of the actual bone, of the cement, which causes some searing of adjacent nerve fibres. So in variable studies, probably at the best side of it, you can get a high rate of response. So spinal mets, just briefly, just to put it in perspective, they're very common. They're found in 2/3 of patients who actually have died with cancer. It's the most common site of painful bone metastases due to this risk of microfracture, the axial load that they're taking, and also due to local invasion. So there's significant morbidity associated with them. And the goal of the non-surgical management is to reduce the pain, improve the functional status, and prevent future fractures. So pre-procedure imaging is vital. So we get an MRI and a CT in everyone. MRI, you're looking for edema and extent of tumour outside of the bone if there is any extra osseous involvement. CT is very good for the bone integrity. So it shows you if the cortex is involved, particularly the posterior vertebral body cortex, which I'll show you. And contraindications do include extensive epidural disease, because we could then compromise that epidural space even more with the procedure, and multi-level involvement is shown to be less effective. So this is an MRI showing, this is a fat saturated, so it doesn't project as well here, but this is a STIR image or a T2 fat sat looking for edema. This is a vertebral body fracture, lower thoracic spine. You can see there's loss of vertebral body height and there's high signal edema. You compare it to this fracture here, which doesn't have much high signal, so that's an old and a long-standing. So we want to see fractures with edema in it. We also look for any involvement of the epidural space, and there's no involvement of the epidural space or paraspinal region in this. So this is how it's done. So just to show your anatomy, in the lumbar spine, so the higher you go, the harder it gets. Cervical spine harder, smaller pedicles, angles are more tricky. Okay, so if we just go back to that, so that's when you'll see, I'll show you, you can't breach the medial cortex, obviously, because then you get into the epidural space. So you've got to be very careful the way you do it. Often you get away with unipedicular, so the cement will infuse everywhere, but sometimes you have to go bipedicular, so a screw down here as well. So this just shows real-time fluoroscopy. This is quite a large 11-gauge needle, and the operator here is just making sure it doesn't go medial to, that's the pedicle, this sort of eye looking at you, that's a pedicle there. So he's just making sure it doesn't go medial to that. And then there's the lateral, so you have to use biplanes. There's the lateral projection. This is the vertebral body here, and this is the posterior part of the vertebral body. So you want to get to about the anterior third of the vertebral body. That's the cement that looks like it's got some radiopaque material varying in it so that you can see it. And then if we just look at, hopefully this will run here, this is just a video showing an injecting. You can see the dark stuff, the cement coming in through the needle, and you'll see it. And you have a certain mixture of cement. You don't want it too viscous, you don't want it too runny. You want to see it coming out in a controlled fashion. You want to see where it's going. Because as we'll talk about, some of the complications involve where it spills if it goes in the wrong place. All right, so I'm just going to hurry on a bit here just so I can get through everything. So complications, bleeding and infection. We're very paranoid about infection because this is in the spine, this is bone cement, so it's a very sterile theatre type setup. And because the last thing we want to do is give someone a spinal infection, which will be very hard to manage. So infection is one of the things that we worry about. Unfortunately, it's very low. And then extension of the cement outside the vertebral body. It can go into the disc, it can go intravenous, and it can go into the epidural space. So this is leakage into a disc. You can see it's gone down into this disc space here. Now, generally not a problem, but can be. It can lead to altered biomechanics, which can lead to fractures. So it's something we try to avoid. This is what's shown like a venogram now. So this has actually gone anteriorly into a vein. Okay, so if this is obviously at risk of then causing pulmonary embolism, because that's what the next side it will go, right side of the heart and then to the lungs. So you just have to be watching that. A small amount of cement to the lungs probably causes no problem whatsoever, but obviously a large amount could cause significant problems. So, and this is just to show you the posterior vertebral cortex. So this is a CT here, and this is an MR. The MR shows all the edema and swelling, and actually that line there is the dura. This is nice here on the CT because the white, which is cortex, is now eroded there. So if you go on and inject cement into this vertebral body, there's nothing stopping the tumour being pushed backwards, okay, and then compressing your spinal canal or spinal cord. So this is just showing going to the epidural space there. And this is a patient with an RCC met who's got epidural extension of the tumour. So this patient had a lot of pain. They needed some form of treatment stabilisation. So they actually had the procedure done, but they had it done with intrathecal contrast. So the operator here has done a myelogram, put contrast in the thecal sac, so that he could see if there was any movement of that, he would then stop and not put his cement in anymore. So this patient had a good response. It had a lot of cement put into to stabilise the microfractures associated with that tumour, and had no compression of the thecal sac. So finally, just got 5 minutes left, do I, Paul? I'm talking about intra-arterial treatments, and this is an area of particular interest of mine where we do a lot of embolisation procedures, particularly occasionally in the bland embolisation setting, but often in the preoperative setting to improve the safety of the operation. So painful bone metastases which may require surgical interventional stabilisation for pain control is the main indication, but also to prevent or treat pathological fractures. Particularly used in hypervascular metastases, so RCC, thyroid and HCC, classical METs. And I'll also talk briefly about surspheres just to show you an example of that. That's used for subcapsular pain related to primary liver tumours and metastases. So this is a 75-year-old man who'd had an RCC MET, and he'd had a previous operation. He'd had an intramedullary nail put in due to a fracture, and he had recurrent tumour. So this is all tumour, and he had significant pains. This is an MRI, coronal MRI, showing the tumour, very large tumour, surrounding in the upper humerus, surrounding that intramedullary nail, but causing significant pain. So we did a preoperative embolisation. This is an angiogram showing catheter in the axillary artery, okay, and this is the tumour here, very vascular. This is a very enlarged circumflex humeral artery and a lot of contrast staining tumour blush associated with the tumour. And this is afterwards, so we cherry-picked it with a microcatheter and embolised it, maintaining obviously flow in the parent artery to the arm. And then that was the operative thing, so they were able to take that humerus out, resect the tumour, and this was the final effect. Dr. Ball had done a total shoulder replacement, and so this is a pre and post operative view. So that patient's now pain-free. And finally, I'll just talk about surspheres, which is selective internal radiation therapy. And it's a well-established treatment for refractory colorectal cancer liver metastases after second and third line chemotherapy. It's also established treatment for primary liver cancer, HCC, cholangiocarcinoma, and other types of hypervascular metastases, such as neuroendocrine liver metastases. It's a just the background, obviously, to remind you, normal liver gets 70 to 80% of its blood flow from the portal vein and 20 to 30% from the hepatic artery. But liver tumours get 90 to 100% from the hepatic artery. So you can target selectively the tumour and relatively spare the normal liver. So it's a super selective arterial microcatheter placement from either the groin or the radial artery. And then we infuse the surspheres. We have to be very careful where they go because they're a pure beta emitter. They have a penetration in tissue of up to 11 millimetres maximum. But if they go in the wrong spot, such as the stomach, they can cause radiation ulceration and a lot of problems. So we're very diligent. So this is just showing coiling of a number of arteries associated with the liver, which actually go and supply duodenum, stomach. So we have to be very diligent in the preparation of these patients. This is a 70-year-old female with metastatic breast cancer. She had right lobe disease predominantly. She had this large tumour here which was causing capsular bulge. She had a bit of fluid outside. She had a lot of pain which wasn't being relieved by opioids and had difficulty. So she had a right-sided surspheres procedure. So this is just showing she had complex anatomy which we had to work up. She had a right hepatic artery and an accessory right hepatic artery. On the angio table these days we can actually do a cone beam CT, so we can actually get a CT image which beautifully shows us the arterial territory. So we did the first run and we thought, wow, this is not being infused, we're not getting any flow down here, and that's when we found the accessory artery, and then we found it here and confirmed it with an EXPA CT. This is just showing what a surspheres looks like. It's quite an elaborate contraption. These are the surspheres in here, and they need to be flushed through, and so this is all connected to the microcatheter in the patient here. And this is showing the response. We do a PET scan pre and post. PET scan is probably the best way of assessing the response because the radiation effect can be hard to assess and see on CT. So this shows the bottom image. If you look at this, this is a sagittal, axial and coronal image of the PET, and you can see how very PET avid that tumour was. And this is our planning. This is the mimicker. I've injected MAA, so we have a planning test run, if you like, to make sure not too much goes anywhere we don't want it, for example to the stomach, and if too much goes to the lungs. It's called the MAA, the shunt study. And this is showing the response 8 weeks later, so a complete metabolic response. And she was pain-free within a week. And this is her 2.5 years later. Sadly, has passed away recently, but she had capsular retraction, so that whole right lobe liver then atrophied down, and she had compensatory hypertrophy of the left lobe of the liver. So that was just saying the combination therapies are very good as well. So more and more we're using combination therapies. This is an example of someone who had an RF ablation followed by vertebroplasty. So in conclusion, IR has much to offer the cancer patient suffering pain. We have neurolysis techniques, ablative techniques, vertebral and bone augmentation, and intraarterial treatments, embolisation. And I'd just finally like to acknowledge my colleague, Dr. Albert Goh, who helped me with several slides. Thank you very much.
Thank you, Richie. Anybody got a question for Richie? I'll just repeat it for the recording.
That was good one. Just the place of ultrasound-guided celiac blocks for the CA versus your posterior approach, which is more similar to what we used to use.
The question is about the ultrasound-guided celiac block.
Look, as a general point, I'm a big fan of ultrasound-guided procedures because you get that real-time vision and you see exactly where it's going and what you're doing. So I just think that the pancreas and the retroperitoneum is not a good place for ultrasound just because it's hard to see. So technically I have never had much luck in trying to do it. Like, occasionally we get asked to do pancreatic biopsies and things, and they're always tricky, but we do try with ultrasound guidance. So I think it's more a visualisation. If you have a very skinny patient, a cahectic patient, they may be suitable, definitely. Absolutely, yeah, I was going to say, yeah, endoscopically, yeah. So definitely, I think that they could definitely have a big role to play. because they've, you know, with all their techniques for biopsying pancreatic lesions, exactly, they will be in a good position to potentially do that. I don't know if any of them are doing it currently, though.
Can I ask a question? Richie, do you do anything for sacral insufficiency fractures? Like, can they have any kind of vertebroplasty or whatever?
Yeah, absolutely. Yeah, no, definitely.
Right.
They can do, yeah. Right. So it's a matter of picking the right patient, making sure they've got still pain related to it. But, yeah.
Yep. Oh, one more. Rupa. Okay.
So I just wanted to ask you for patients with the bone metastasis, stage 3, would you do palliative radiation before or after the radiation?
Well, generally speaking, the patients have been, and it's probably a referral pattern, you know, historical, get radiotherapy. So we would probably not even see them or hear about them, you know, unless they probably hadn't had a response to radiotherapy, or there was a reason they couldn't have radiotherapy. So we don't get them, it's not like at the moment, we don't sort of say from the start, which way should we go? And I think that, you know, certainly more and more, there's more evidence supporting that potentially, you know, good stabilisation. And that may be that, you know, I haven't personally, we haven't started those conversations enough yet, and we probably should, but they may actually like the fact that the vertebral body is more stabilised prior to them doing radiotherapy. Yeah.
Okay, all right. Thanks again, Richie, for a great talk and terrific slides and pictures.